How's it in the back? We okay in the back? Good? Yeah? Okay? Yeah? Yes? No? Okay? Yeah, all right. Super. Let me just... All right. So just a couple of housekeeping things. So as I mentioned, I decided to finish dementia today because there's only about 6 or 7 slides, and then we'll start epilepsy. Then Wednesday, we're having Professor Patrick Chauvel, who's the senior epileptologist at the Cleveland Clinic. He's going to come in and talk at the beginning of the Wednesday class for 15 or so minutes on the different kinds of odd phenomena people experience as auras in epilepsy, or when you stimulate certain brain areas as you're trying to prepare whatever the surgical plan will be. I think you find it really, really fascinating. And I think what I'm going to do, I'm going to send you a paper. You don't have to read it if you don't want, but for those of you of interest, it's a paper that he did in the 90s, like listing 10 or 11 patients and the kind of things they experienced. It would prepare you a little bit for what he's going to talk to you about. Okay, so today we're going to finish dementia. We talked a lot about Alzheimer's disease and amyloid and tau and amyloid PET scan and risk factors, presenting symptoms, and now we're going to switch to another large category of dementia, which are called frontal dementias. And as you might guess, they present just the opposite of Alzheimer's disease. They present with problems in regulating behavior, and it can be both cognitive behavior and interpersonal social behavior. As that disease progresses from the front to the back of the brain, you eventually get other problems similar to an Alzheimer's patient, and at the end they look the same because they've lost, severe widespread cortical function. So basically just a few facts here. Executive dysfunction at the start, their memory's good, just the opposite of Alzheimer's. Behavioral deficits are really prominent. Personality changes. My loved one is not the same person anymore. They're not the same person. Impaired judgment, insight, odd, inappropriate behavior could range from being too labile in terms of their temper or making inappropriate sexual approaches to people that was not part of their character before. Sexual indiscretions, frontal release signs, as we discussed in the clinical part of the exam, and finally, a much earlier onset in general. There's at least 3 subtypes that have been defined, and I'm not going to go into the details of any of that. It's too much for this class, but the Memory and Aging Clinic at UCSF sees literally hundreds of these patients, and they're really doing some excellent work. For anybody interested in this and they were looking for lab experience, that will be a really fine place. So this is what the brain looks like, and it's not a pretty sight. This is, you can see here, the back of the brain is very well packed. In other words, the gyri are flush and the sulci are not prominent. If you look at this case of frontal temporal dementia, I think you can see how clear it is starting frontally. Severe atrophy. In fact, in the literature, it's often referred to as knife-like atrophy. It can be so bad. And you can see here's another case. It gets not just frontal cortex, it also gets anterior temporal cortex and amygdala. So as you'll see later in the course when we talk about the neurobiology of emotion and the role of orbital frontal cortex and amygdala, this will be smack center. And these areas are smack center in determining how you do your everyday social and emotional processing. So you can see since these are going in these patients why they have problems. Here's an MRI scan, and you can see the very severe atrophy of the frontal lobe. And this would, of course, be a cut like if it went right through there, an axial cut through the brain. And again, the pathology here extending to the medial frontal cortex also. So all these areas involved in executive control. So here's a moderate FTD patient, and you'll see he's just doing slightly inappropriate things. He has a very high intelligence. This is...
So maybe we can start by your telling me why you're here today.
I'm part of a research group that's checking me out to make sure that my is still in check and still in balances.
Okay.
And I'm going through all sorts of tests and exams to make sure that I'm still 100% me.
Mm-hmm. And how do you feel like you're doing?
I feel like I'm doing fine.
Mm-hmm. Any problems
Very
at
little
all?
insight.
No.
Okay. All right.
Common.
Say as many words that you could think of that start with D, and we're going to give you 1 minute to do that. Okay?
Frontal lobe test,
All
word
right.
fluency. How many
Go.
letters can you?
Disgust,
How many words with a
demanding,
certain letter?
disgusted. Day. Dell.
Lots
Detail.
of problems. Word fluency is impaired.
Denali.
Repeats words, perseverating. This is a man with an extremely high pre-onset of disease IQ.
Any words that start with the letter D.
Demarc. No, there's dilatorial. Disgust. Disdain. Okay.
Okay.
Mhm.
All right, that's 1 minute. Very good.
All right.
Could you give us any examples?
Watch this.
If one book by a certain author was good,
You see what he's
20 of
doing?
them had to be better.
It's completely inappropriate. He coughs in his hand, wipes it on his clothes. That's the kind of thing that starts happening. They're a little bit subtle.
So those
You may
kinds
know
of things.
people who
That's
do
right.
that now,
You
but
have
you're not
quite a
supposed to.
record
But that's not
quite an
correct.
album collection.
And
too.
you
Yes,
can
I
see the
do.
wife is
Yeah, how
having to
many?
deal with this and
6,000.
is pretty horrified, but she's
6,000.
been living with it.
That's not many.
What kind of music do you like?
Yeah, he
Rock
has a
from the
massive
60s and
rock and roll
70s.
collection. So that's a mild
And
case,
What have you recently
but a
added to
serious
your
case.
collection?
Not.
Here's a very advanced case that my colleague Bill Jagus is examining, and he just has lost all cortical function. He can't do anything. And you couldn't tell at this stage if this was an end-stage Alzheimer patient or an end-stage frontal temporal dementia because the cortex, what started this way in Alzheimer's, the sweep, this way in frontal temporal dementia, but eventually it's all impaired. And you just see this patient who's kind of out of it, a bullock, can't follow commands. So how you doing? Let's come and stand up for me. Come this way, okay? I want you to sit down over here. Can you do that? Take my hands. Let's try this. Come with me. Come on. So he's just completely disconnected, right? No language. Good. Let's just see you walk for a minute. Can you sit down over here? Good. Come on, I want you to have a seat over here. Okay? That's good. That's good. Very good. And I don't need to belabor this case because everything you try to do with him, he can't do.
Turn around.
Because he has a global cortical dysfunction.
Can you sit down? Sit down here. That's good.
A little bit of a grasp reflex there. Remember the grasp
Look
reflex?
at me. Can you see me? Good. Can you hold your hands up like that? Hold your hands up
I
like
think
that.
we've seen enough. That's, hopefully with biomedical research, we'll eventually be able to stop the progression of these diseases. There are animal models. There's tau deposition in FTD. There's been a gene identified in one of the syndromes, chromosome 17. So it's a really exploding field of research. But again, just to hammer home the point, if you remember earlier on the dementia discussions, I showed you this early PET glucose, picking up glucose in active brain cells, and I showed you this initial hypometabolism in the posterior brain areas, first actually reported at Berkeley, and now you can see the PET uptake in someone with frontal temporal dementia. As you can see, there's a severe loss of activity in the frontal lobe. So there's physiological marker, and now we have a PET marker for frontal temporal dementia. I'm not going to go into it in detail, but there's a tau PET marker just like there's an amyloid PET marker. So you can begin, as you're trying to differentiate early on what is the syndrome, and you're not sure clinically, but you can now categorize people based on their underlying relative uptakes of amyloid and tau. And as we'll, again, later in the course, remember, tau is the thing that gets deposited in progressive dementia and repeated head blows. We'll get to that later in the class because it is, as many of you probably know, it's an emerging health crisis. Finally, these are degenerative disorders where cells are dying for whatever reason. That's what we're trying to figure out so we can get treatment. There's also vascular dementia, and this is basically seen, this is seen with advanced small vessel disease, typically increased by diabetes or hypertension. We talked about that, and you get these little small infarctions all over the place. Eventually they sum up, and you've got so many areas of small taking out of white matter connection that the system doesn't work as well. And you also get progressive dementia. And I said there's a big socioeconomic difference in who gets what. So the neurodegenerative disorders really go like this. They just slide progressively. The vascular disorders actually often have a stepwise course. You pick up one infarct, you stabilize. You pick up another, and so on. There's more of a staccato course. But the MRI scan clearly easily differentiates them. The MRI scan in Alzheimer's doesn't have any vascular changes in most cases. Well, you can have both, but in multi-infarct dementia, you clearly see evidence of infarction and subcortical pathology, usually more prominent in the front part of the brain. Okay, so there's a few reversible causes of dementia that everybody gets when your loved one goes in and gets evaluated. And this, I have to figure out how to undo some of these things because Mark Desposito made this slide, and I think he was out of it when he did it, but we'll just see. Because he's got all these fancy things here. I don't even know how to do that. Okay, it gets worse, trust me. Depression is a big cause, pseudo-dementia, right? So in an older person, you need to ask because dementia can masquerade as a Boolean indifference, and it's very important, particularly if they've had a death of a loved one recently, because that often cascades into a depressive episode even in an older person. So depression must be considered because that's not a dementia, and that's treatable. B12 and folate deficiency, this is a biggie. B12 is, every single person who gets evaluated for dementia gets a B12 level. If you lose B12, your spinal cord deteriorates, your proprioception and vibration goes, as we talked about earlier in the sensory exam part of the course, and you get a progressive dementia. It's pretty simple. You find low B12, monthly injections of B12, and the person will reverse. Now, whoops. Hypothyroidism. Again, indifferent, slow, not sharp, could be called depression, could be called dementia. Don't get fancy. Just make sure everybody gets a thyroid level because if they're hypothyroid, you can replace it and they can do extremely well. They will improve. They can go back to normal. And then finally, and this is where Mark, I think, really lost it. Woo! What is that? What is that? Is he trying to? Looks like he's trying to induce a seizure with strobing, neurosyphilis. And you say, oh, gee, no one gets neurosyphilis. Don't bet on it, right? You must check because you don't know for sure. Primary neurosyphilis presents with a genital lesion. Secondary neurosyphilis is delayed and usually just has a maculopapular rash 2, 3, 4, 5 weeks later, and then it's gone, right? And if it's in your body, it can start growing and setting up light housekeeping in your brain. And you get progressive dementia. It used to be called grand paresis of the insane. In fact, Al Capone died of neurosyphilis in Alcatraz. And so you need to check for that. And particularly in the HIV world that we live in, there's been a tremendous increase. If you take someone with AIDS and they're positive for HIV, they also have a higher likelihood of having a second disease such as neurosyphilis. So everybody has to get checked and taken care of, okay? All right, so that's just on the slide. These are the things we do, the history, the neurological exam, the blood studies, the various tests. We're not going to go through those. You don't need to know those. They're just there. Finally, prion disease, proteinaceous infectious particle. And I don't know where this whole field is going, but I do know that when Stan Prusner reported that he had a transmissible disease that passed through viral and bacterial filters, everybody said he was making a lab error, and he got a lot of flack. Turns out he was right, and he ended up getting the Nobel Prize for it. And it is a proteinaceous infectious agent. It's being linked now to lots of diseases. I don't know where the story is eventually going to go. We know that it's very common. It's called Kuru cannibalism in New Guinea. Basically, the tribes, when they kill another tribe person, they'll eat the brain. They transmit the disease. It has a very long transmission period in animals. It's 2 to 3 years. So it took a while for them to fulfill Koch's postulate, which means to prove it's infectious, you have to isolate it, put it in a healthy animal, and produce the disease. But with a 2 to 3 year latent period, you've got to wait a long time. So it was a little shaky in the beginning. Creutzfeldt is another prion disease, Creutzfeldt-Jakob disease. I've only seen about 10 cases, but they are all bad, and they're all fatal. And it usually has about a 4 to 6 month time to onset. And with course, person just starts with confusion. They often have myoclonic jerks like this. Do you see what I just did? See that? I don't know if can you see it in the back? That's it. You see that, someone's demented, they probably either have Jakob Creutzfeldt or they have another variant of Parkinson's, Lewy body disease. It's transmissible. It's been in surgeons have got it. There was in people who they didn't know had it. They were still in the indolent period. There was an unfortunate pituitary extract where they were getting pituitary hormones for patients from cadavers, and one of the cadavers, they didn't know the patient had Jakob Creutzfeldt. A lot of people got it. A lot of people got Jakob Creutzfeldt, and it's fatal. It's a bad disease. And then finally, bovine spongiform encephalopathy. This Jakob Creutzfeldt usually onsets late in life, 50, 60, 70. Bovine spongiform encephalopathy basically onsets in people in their 20s. And there's been about 30 cases in Europe. They may have it under control. It was a contaminated beef specimen, had this virus, and it got into the food chain. We haven't had any cases in the U.S., but I think there was one report of an animal with the prion disease in Canada. So stay tuned. We'll see. All right, so we finished dementia, and you should have a pretty good overview of what's going on. And now let's switch to epilepsy and get started. I don't think we'll get finished, but that's okay. So first, what is epilepsy? Normal cells, if you look up here on the top, normal cells, if you put an electrode near them, they're spiking. It's some kind of pattern. An abnormal cell, and this is a schematic of an abnormal cell. It may not look that bad, but it could still be epileptic. It fires in bursts. These are the clear local epileptic discharges you see in a cell that may produce a seizure. So let's talk about this a little bit, because there's a big difference between having one seizure and having epilepsy. Okay? What do I mean by that? If I put an IV into everybody's arm in this room, right? You're all, and I got a big vial here of insulin, and I inject insulin into everybody in this room, and I drop your blood sugar to about 15, you're all going to start seizing. If I now stop the insulin, infuse glucose, you're going to stop seizing. And you won't never have another seizure. So you're not epileptic. You've had a seizure. A seizure is a one-time event. Epilepsy means you have a predilection to have recurrent seizures. Okay, very important distinction. The causes are manifold: genetic, congenital abnormalities, perinatal difficult deliveries with a low APGAR scale, anoxia, stroke in kids, infections, encephalitis, meningitis, brain tumors, vascular problems, stroke, hemorrhagic strokes, ruptured AVMs. They can all produce abnormal nearby cells, which could have abnormal firing and may produce a seizure or recurrent seizures, which means you now have an epileptic patient that you have to not just give them glucose, you have to figure out what's the cause of the epilepsy and how we're going to help the patient. Toxic, is very, very common. We see tons of this. The one that the catecholaminergic toxins like cocaine and speed, if you take enough, you can have a seizure. I've seen untold people with a new onset of a seizure from a heavy run of cocaine. Again, if they don't do any more coke, they're not going to have any more seizures. So, now we did have a series of patients we looked at Highland General where actually the cocaine induced the seizure, but actually we found an underlying structural abnormality that it was probably on the edge of seizing and the cocaine tipped him over. So, but the most common thing is to happen in a normal brain. Alcohol withdrawal, delirium tremens, heavy alcoholics. I mean, people are drinking heavy every day. When you withdraw them, they get a syndrome where they become tremulous, they hallucinate, and they can have grand mal seizures. And you have to be very vigorous in treating them. Because if you treat them, they're going to be okay. They'll be withdrawn, and they won't seize again. But during the actual withdrawal, it can be a very difficult situation. And then metabolic, these are all reversible. So you go to Burning Man, and you drop your sodium to 121, right? And you start seizing. If the doc gets your sodium back up to at least 128, or normal being around 140, you're going to stop seizing. So these are metabolic dysfunctions that are not going to be producing epilepsy. Not going to produce epilepsy. Seizure, epilepsy, 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 epilepsy. Recurrent seizures, okay? Important distinguishing point. And then sleep deprivation, but sleep deprivation per se doesn't produce a seizure. Sleep deprivation will, if someone has they don't know it, but a predisposition to seize, they may seize. And in fact, when we're evaluating people for epilepsy, what you do is you order a sleep-deprived EEG. And the reason you do that is when you go to sleep, you probably will notice this. Somebody who's going off into stage 2 sleep will have a jerk. You ever notice that? A little jerk, right? Right at that little jerk period, you have a heightened level of cortical excitability, basically. So you're more likely not only to have your normal little sleep transition from stage 1 to stage 2 sleep, you may also have a seizure. So we sleep deprive people to try to we want to bring it out and document it and figure out where it's from, etc. So sleep deprivation. And then lastly, febrile seizures. Febrile seizures are really common. The incidence of epilepsy is about 1% in this country. Do the numbers. 3.5 million people. Saliency. Anybody know anybody personally who has epilepsy? Not professionally, personally. Okay, so it looks like it's about 10, 15, 20% of the room. Pretty common problem. And so 3.5 million people have epilepsy, but about another couple million kids have febrile seizures. Does anybody know about febrile seizures? Did you have a SIB that had it? Nobody? Yeah. What happened? Did you see it? What did he do? He what? He was jerking? Okay. And then, how old was he? 2. And how high was his temperature? 104. Yeah, that's a classic febrile seizure. It freaks everybody out, appropriately so. But if you lower the temperature and keep it under control, the kid's not going to seize again. And the treatment actually is not medications. The treatment is to make sure to watch if the kid gets a runny nose, you monitor that temperature and don't let that temperature get up over 100.5 or 100. Well, keep it down. Did he do okay after that? Yeah, so he had a one time. Yeah, so that's great. So they managed it all appropriately. So you can see there's that's why you do a neurology residency, and some people actually do a subspecialty for a couple of years just in epilepsy. It's a very, very big field with lots of interesting moving parts. The age of the person determines in part what kind of seizure they're going to have, and that's not so hard to imagine if you just look at this nice little simple chart here. The younger the onset of the seizure disorder, whatever it might be, the more likely there was a perinatal injury or a congenital malformation, basically. And as you get older, you can see in your 20s, it's more likely to be a brain tumor or vascular disease or trauma. So it really depends. These are not hard and fast, but they give you a little bit of a feel for, age. It has a somewhat of a determining factor on your likelihood of having a certain type of seizure. This is a very common one that we see in our epilepsy work, and particularly in kids. This, if you look up here on the top here, see this thing right here? That's in a thickened cortex. The cortex should really be only 3 to 4 millimeters, right? We have this very, very thickened cortex in this particular area of the brain, in this person up in the frontal lobe, and that's what's called a focal cortical dysplasia. It's a developmental problem where the cortex doesn't get its perfect 6 layers and often overgrows, and these are very epileptic. And, I would say, I don't even know what percentage of our cases have these, but a fair amount of people who have uncontrolled epilepsy starting as kids have a focal cortical dysplasia. This one's obviously very simple to see. Very simple to see, but they can be very small. In fact, you can miss them on MRI scan. 3T MRI, you may not see it, but you think there's a cortical source because of what the onset of the seizure was like. And we will see cases like that where we isolate, this is the epileptic focus, we take it out, it goes to the lab, and it comes back focal cortical dysplasia below the resolution of the 3T scan. So this is a big issue in kids, particularly, focal cortical dysplasia. You can see these are neuronal migration disorders. There's usually a track going down towards the thalamus, where you get these bursts of cell migration during fetal development, and they can get stuck either in the white matter, or they can end up, migrating to the cortex, where there could be a small focal cortical dysplasia. So these syndromes were not even introduced into the field until 1979. Now, that may seem like ancient time to you, but it's really not in the history of kids having epilepsy. And now we know a lot of kids have these dysplasias, and MRIs help quite a bit. So, I wanted to talk about 2 kinds of epilepsy. This is how the epileptologists split them. One is generalized epilepsy. The key thing in generalized epilepsy, there's multiple kinds, is that the person loses consciousness. They are not with it. It could either be like your little brother, who at age 2 was totally out of it and having generalized tonic-clonic seizures, or it could be someone who has a seizure onset in the temporal lobe and they just... That's a temporal lobe seizure, and they're out of it, right? So that's a generalized seizure, too, because it impaired my consciousness. I couldn't interact with you during it, right? So these are what we call generalized. And we'll talk a little bit about this one, because this is a kid genetic one, absence seizure, very important, particularly anybody who's going to be a teacher. And then you have focal seizures. For instance, let's say you have some kind of abnormality near your motor cortex on the left side. Your seizure may just be twitching and jerking of your contralateral hand. It may never generalize. And you're awake. You're looking at the patient and their hand's jerking, because they have epileptic activity. Now, that seizure can spread, as I'll show you, and turn into a generalized seizure, but it may not. It may just stay focal. So generalized and focal. And then focal with secondary generalization, which is what I just described, with somebody with a motor onset, and then it spreads to the leg and to the face, goes across the corpus callosum, and then you end up like your brother with a generalized tonic-clonic seizure. Secondary generalization. So again, it's an abnormal discharge of neurons, sudden and brief abnormality of brain function. And the kind of dysfunction you have depends on where the seizure focus onsets, right? So if it onsets in the somatosensory cortex or the parietal lobe, your seizure may start with tingling in your right hand. If it starts in your right motor cortex, it may start with jerking in your left hand. If it starts in your temporal lobe, you may just go out of it and or have a aura prior to that of a strange experience, deja vu, perceptual distortions, and these are what Professor Chauvel will actually talk to you a little bit about. They're extremely fascinating, and they also tell you where the seizure is probably coming from. If you have an aura, and you can localize that aura to a brain area, let's say a hissing sound, auditory, a strange perception, somatosensory, etc. That helps the doc figure out where's the onset, because that's what you want to know in terms of treatment. And there's a very high chance of having a seizure in your lifetime. It's somewhere in the range of 2 to 3%. So these are not uncommon events. As I mentioned, excluding febrile seizures, epilepsy is about 3.5 million cases in the U.S., of which roughly 15% do not respond adequately to medication and need to be evaluated for other interventions, usually either the kind of things where we do it, localizing the epileptic source and doing surgical removal, or other approaches to non-medicine approaches to controlling. So as I mentioned to you, here's simple partial seizures. Whoops. Tingling, somatosensory, motor twitching, flashes of light, ringing, hissing, and noises. Olfactory, very interesting, disagreeable odors often, just a very funny smell, basically. You say, if someone has a grand mal seizure, and they come to, and you talk to them, and you say, Mr. Smith, did you have anything happen before you went out? Because they don't. Once you are having a generalized seizure, you're out, right? So, what did you remember? And if the patient says to you, "I had a weird smell," you know exactly where the seizure is coming from, and it really helps you in terms of localization and treatment. You can get some funny autonomic seizures, which don't have generalization and loss of consciousness, but have autonomic symptoms of, for instance, sweating, flushing, epigastric pain. These are the more common ones. But remember, when you have a generalized seizure, it kind of wipes out your memory banks. So a lot of people who actually have probably a focal onset don't remember it. So we really only get a good history of an aura probably in 20 or 30% of people. Yeah. I'm sorry, say what?
I've read that once people learn about the words on their behavioring, that they can prevent the seizures if they smell something very pleasant.
No, I don't think so. Well, if you get an aura, sometimes with heavy mental effort, you can control the spread, but usually you can't. I don't know of anything of flipping. Yes? No? Just stretching? Good. All right. Other questions? We good? So these are really important. Simple seizure. Here it is. This guy's, basically has this rhythmic spiking in his EEG, high-frequency discharges. Here's a partial seizure with a hand jerking. Here's one, again, focal motor. Here's one with tingling from somatosensory cortex. Here's one coming in auditory cortex with an onset of a strange sound or distorted sound. You usually don't get formed things. You don't hear, Anthony. You don't hear a name. You don't hear a formed thing. You hear some unformed sensory percept. Same thing with vision. You typically don't have formed hallucinations. Your aura might be a flashing light, or it might be some strange perceptual distortion. Usually nothing completely well formed. Now let's talk about the Jacksonian march, described by Ewlings-Jackson. Tremendous neurologist, really quite observant. And basically, this is really important. But we all know what the homunculus is now. We know, right? We've got an organization where your face is, and your hand area is, and your foot area is. What he described was the Jacksonian march, which meant basically the seizure started here in the finger, or wherever it could start in the leg, and then it spread to the arm, and then it spread to the face, and then it spread to the leg. So it marched along the homunculus, engaging more and more cortical areas, producing an overt behavioral output of this progressive march of the seizure focus. What can happen after you've had that Jacksonian march, you actually can then generalize, and the person may have a generalized tonic-clonic seizure. Now, sometimes, maybe the person doesn't know they had a Jacksonian march, but if someone observed it, you're golden. The other thing you may say in people who've had onset in one area, and then it generalizes, right after they start to come to, and you check their neuroexam, they'll have transient weakness in the limb that the seizure focus was in. This is called a Todd's paralysis, Todd''S. It's a very important, again, neurological finding. So if I see someone, they've just had a seizure, and I raise their two hands up, and they're out of it in the bed, and this one goes, they got something wrong on their right side. Probably the seizure started on the left side. So these are all important things for the clinician who's trying to figure out what's going on. Now, petit mal seizures are really, really, really important and misunderstood. People often think of them as a temporal lobe seizure. They are not a temporal lobe seizure. They're a genetic seizure disorder. There's about a 30 to 40% family penetrance, so autosomal dominant. And basically, this is basically a petit mal. So as we're going through the class, and I'm trying to formulate exactly what I'm going to say to you, I've just had 3 petit mal seizures. Did you see the transient lapse just like that? Not much, right? Just had another little one. So they can be as brief as that. Brief loss of consciousness, couple 3 seconds. If you're lucky, the patient will not only have the brief loss of consciousness, the eyes will blink at a 3 per second rate. So then it's easy to tell. So if they do, that's a petit mal seizure, period, end of story, right? So you got to be careful because sometimes these kids are diagnosed because they have so many of these a day. I just had another one. They can have 200, 300, 400 a day, and they're diagnosed as attention deficit disorder, when in fact they're having multiple petit mal seizures, and they're very easy to treat. Blinking 20% of cases, etc., 3 per second, spike wave, and unlike a generalized tonic-clonic seizure, where you're really having heavy-duty seizure activity, you're always out of it afterwards. You don't come to for minutes, hours, even longer sometimes. In a petit mal seizure, you have and then you're right back to normal consciousness. So there's no postictal depression of the person's behavior, again making it harder to suspect it's a seizure. So here's a petit mal seizure. The kid's reading a book. The kid stops reading the book, stops and stares. And he will stare for as long as the seizure activity goes on. You can see here's an EEG, and you see this very nice 3 per second spike wave. This particular petit mal seizure looked like it lasted about 8 or 10 seconds, but they can be much briefer than that, and then they're even harder to figure out. So 3 per second, beautiful 3 per second spike wave. This particular patient, they say, blinked. Here's another girl. That's her normal, happy little face, and you can see while she's having an absence seizure, she just stares quickly. And sometimes, 20% of the cases actually blink, making it easy to diagnose. Don't miss these. So here's a really nice kid. His dad, this is publicly available. What we try to do with kids when we're trying to induce a petit mal seizure is we have them hyperventilate. What does hyperventilation mean? Hyperventilation means you do for about a minute. You try to decrease the blood CO2 level from 40 to 25, and that can induce a petit mal seizure. So watch this boy. He's actually going to produce a petit mal seizure for you, so you'll see what it looks like.
Hi, Tyler.
Hi.
What are we here to do today?
Blow on the piece of paper to see what it looks like to do a seizure.
It's hard to get kids hyperventilate. You have them blow on
Go ahead and
something.
start whenever you're ready.
Nice kid. It's getting almost to a minute. See, he's having a
Tyler.
petit seizure. See his eyes blink?
Tyler.
He's out of it. That's it. Slow down, Tyler. Anyway,
Tyler.
that was the seizure,
Tyler,
right?
you
And
can
if he
stop.
hadn't blinked, you might
Tyler.
he'd just be staring at you for a few seconds.
What?
And if you notice,
You can stop now.
he's right back to normal. Okay.
Take a deep breath. You're okay. You can stop. Stop breathing.
Okay. He's a funny kid. So, yeah. Actually, what they use at Children's Hospital is a pinwheel. So the pediatric neurologists, when they're diagnosing these kids, they have them blow on a pinwheel and keep it spinning, basically. And that's the same thing to dropping their PCO2. So generalized tonic-clonic seizure, impaired consciousness always, collapse to the photonic body extension. That's the tonic phase. Tonic and then clonic, right? So first rigid and then jerking. Basically, about 20% lose bowel or bladder function during the seizure. They have a prolonged postictal state where they're out of it for a substantial period of time. And that substantial period of time, as I said, could be 15 minutes, 30 minutes, an hour, 2 hours, etc. And as I mentioned, if you notice a postictal paralysis, one side's not moving well after they stop seizing, that may give you a clue to where the seizure started. Todd's paralysis, famous neurological sign. So here's a generalized seizure on an EEG, and I want you to look. What you notice at the beginning here, here's where the seizure starts at the red arrow, and you get this massive high-frequency discharges, very rapid, all over the brain it spread, right? And that's the tonic phase. Then it slows down the rate a little bit, and you notice here it's transitioned into intermittent spike discharges, bang, 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 and that's the clonic phase. So you go from the tonic with high-frequency discharge to the rhythmic discharge for the clonic jerking phase. Again, this just shows you what you got here. The one thing I put this slide up here for, if you look on the right, there's the tonic high-frequency discharges. Here's the clonic phase with the more time spread out discharges. And then postictally, your EEG's flattened. You have a severe suppression of cortical activity. That's the postictal phase. That's when the patient's out of it laying in bed. And that's what does not happen to the kid with petit mal epilepsy. Okay? So here's an example of somebody having one of these seizures.
Watch yourself. Is the main on track?
He's already in the clonic phase. Foaming at the mouth.
Yep, main's on.
Don't put anything in the person's mouth. Turn their head on the side. Don't put your finger in their mouth. There's nothing worse than a human bite. You're better off getting bit by your dog.
So I'm documenting it for the doctors.
That's fine.
I typically do this when I go to the neurologist.
The rate of slowing down of the clonic jerking.
Okay, you want me to go to University, please?
Okay,
Sure,
so
I'll do
that's,
one.
very common. You see many of these patients. Your job as the clinician, let's say this young lady comes into the emergency room, you got to figure out what was the cause of this happening. Maybe it's cocaine, then it's not a big deal. Maybe she's diabetic and had too much insulin, then it's not a big deal. Maybe she has an AVM. Maybe she has a brain tumor. Maybe she has who knows what. And that's when you start figuring out what's the cause of that so that you can fix it and get control of her epilepsy. So that's generalized seizures. Now, complex partial seizures are seizures that we see tons of, right? I mean, how many of you seen now, Colin, do you think, down at Irvine? Dozen, yeah. It's very, very common. And those are seizures originating from deeper brain areas, typically the amygdala, the hippocampus, the orbital frontal cortex, sometimes the insula, and they have a totally different seizure presentation. Impaired consciousness, they often have dreamy states. They feel odd perceptually, and that's what Professor Chauvel is going to really talk to you about. He's a world expert on that, so I'm not going to say anything else about that. Sometimes formed hallucinations, sometimes music, sometimes formed visual hallucinations. When the seizure starts, In the visual cortex or the auditory cortex, you don't get formed hallucinations. You get primitive, shh, light, something like that. When they start in deep brain structures connected to memory areas, you can actually reinstantiate a more formed hallucination, right? Something that actually has maybe a picture or an idea or a scene or a formed piece of music. These are seizures not originating from the primary auditory areas. They're deep in the brain. Sometimes chewing movements. Sometimes picking at clothes. Occasionally a language disturbance. I've seen about 7 or 8 cases presenting with a Wernicke's aphasia when they actually were having repetitive seizures in Wernicke's area. So different funny things can happen. So again, this is just a little slide for you to take a look at to remind you of all the typical features. Basically, impaired consciousness, sometimes not that common, formed visual or auditory hallucinations. Olfactory, bad smells, very common, very common. Again, the seizures typically originate, here's some spiking in the left temporal lobe. You'll often see picking at clothes, staring into space. They typically last, the actual seizure is usually about 45 to 90 seconds. And then the postictal phase is typically 10 to 15 or 20 minutes. You know, everything is dependent on the individual case. So here is an example of a young boy. He's having a complex partial seizure from temporal lobe pathology, not a petit mal seizure. The petit mal, simple medical treatment. The kid grows out of it typically by teenage years. You're done. Something coming from the temporal lobe, it's not going away. And you've got to figure out what it is and either take it out or control it with seizure medication. So we'll stop with this movie, and then we'll finish up a few more slides on epilepsy, and then on Wednesday, and Professor Chauvel will take over. So here's a boy having a complex partial seizure. This whole time he's seizing. This is all a complex partial seizure.
You all set? Isaac, where are you going?
That's a seizure. Walking maneuver sometimes, cycling maneuver, emotions. He's out of it. This is not...
Do you know your name?
He's totally confused. He's postictal.
Do you know who I am?
But you see, you know, the petit mal's eye blinking, the complex partial is much more, right? So when we start back on Wednesday, I'll show you one more complex partial seizure. We'll finish up a little bit more about epilepsy, and then we'll move on to Professor Chauvel. Thank you.
What?
Isaac.
Do you know my name?
Chelsea.